All right. Everybody hear me good? Somebody just give me a little dot in the box. Make sure y'all hear me good. Gotcha. Thank you, Mick. All right. So tonight is gastroenterology emergencies. Parts of it are going to be a tad bit of boring, but we're going to try to make it entertaining as much as possible. Oh, sorry. That change over here. All right. So medicine, again, applies the fundamental knowledge to provide basic information, care, and transport based on assessment and findings. I think that's going to be our common slide for the next little while. Abdominal and gastro disorders, anatomy, presentations, and management of shock associated with abdominal emergencies and gastro bleeding. These are some of the things we're going to go over. Anatomy and physiopatho assessment and management of acute chronic gastrohemorrhaging, peritonitis, and ulcer diseases. We'll touch about all that. We'll talk about blood pressure in hemodialysis patients, anatomy and physio again, about complications related to the renal disease, kidney stones. Those are all inducts. So we'll start from here. So abdominal pain is common cause of often identified by the EMT. You don't need to determine the exact cause of abdominal pain, but you should be able to recognize what life-threatening problem and act swiftly in response. So that way we want to know exactly what's going on. If the patient's starting to have pain and they're anxious, you may have to require some rapid assessments and emotional support until, if they need pain medicine, the ALS provider arrives there. Or so just tell them you understand them. Don't tell them suck it up, be a big girl. But let's be compassionate about things and some of the things you should recognize. All right. So abdominal cavity contains the gastrointestinal system. Let's see. It's the genital system, the urinary system is made up of solid and hollow organs. We'll go over that in a little depth and more. On the solid and hollow organs, it's three systems. It's the gastro. Oh, I'm sorry. I'm reading myself again. I'm trying to read off two screens. That's what's got me. All right. So here's our solid organs. These are important. You're going to probably see this later on the test. Which one's your solid and hollow organs? Which is your liver, spleen, pancreas, kidneys, and ovaries. Injuries to the solid organs can cause shock and bleeding. Heavy, if your spleen ruptures, or you can have cirrhosis of the liver from heavy drinking. Kidneys will shut down. You'll start to become jaundice and stuff like that. So keep those in mind as you're starting to test these. There's ways that you can do an abdominal assessment. And when you tap on them in certain ways, that they'll call referred pain. And the referred pain will kind of give you an idea if it's solid or hollow. All right, so here's some of your hollow organs. Gallbladder, your stomach, small intestines, large intestines, and urinary bladder. If there is a perforation of one of the hollow organs, the contents will leak into the contaminant of the abdominal cavity. So that's kind of important. If you notice that they're starting to have a lot of vomit, or if they vomit and it's of what color, that's important to you. If you need to know, look, that's green, or obviously we'll get into the upper GI and lower GI in a little while, but that's important. We need to know what color. Some facilities will beg you to bring that contents with you. I don't think I want to do that. So that's going to be on them to find that on their own. So sorry, I'm just not cool about that. So here's some pictures of your solid and hollow organs. So you kind of have an idea where they are. I'm trying to get my mouse on the right page. So you get your liver, your kidney, your ovaries, your spleen, pancreas, and kidney. I hope to goodness everybody kind of knew where all those are. And then you'll have your gallbladder, urethra, your large intestines, fallopian tubes, the urinary bladder, your uterus, small intestines, and stomach. It just kind of breaks it down so everybody can kind of get an idea of where these organs are, what's solid and hollow. If you're just looking at the picture, you kind of get an idea of the difference in them. No, if you have your bladder ruptures, it's not going to kill you. It's going to be extremely painful. Yes, it is fixable. but I'm sure if your ovaries rupture on females, it's going to be extremely painful. You're going to lose a lot of blood, and you're going to definitely need surgery for both of those. So those are important on why we need to know which ones are which. So we'll go here. So I put these in. If you can tell the difference, if y'all will look at the top where it says anatomy and patho, or physiology, sorry, that is yellow. Well, mine are orange. And that's the reason why I was just trying to add some extra information in there for you guys. So what this will do is kind of help. I just want to help you out with some information. All right, so this is broken down into the quadrants. So you will hear the 4 different quadrants. This is your right upper quadrant, left upper, right lower quadrant, and your left lower quadrant. These need to be assessed in a certain manner. So if you're having pain down here, everybody can see my cursor. Is that we on the same page? Is that right? Dot somebody? I keep circling until somebody tells me. All right, good. Thank you, Victoria. All right, so if we're having pain down here, do I want to start in this area assessing the entire abdominal area? No, I do not. I'll just keep going. So I do not want to have to assess in this area. I want to start on the opposite side and work my way around it. So if I start over here, I poke. I don't want to poke real hard. I just want to, no, you do not need, if tenderness is around it, correct. Because then if I start here and I move to here, all of these other quadrants are going to hurt. So if you happen to know this right here, just so y'all get some landmarks, this is the belly button. So if you know these quadrants and you know what body organ, hollow or hollow or solid, is in these areas, you will know potentially what's bothering them. So if you start over here, you're going to be having more of your small and large intestines. You move up into this area, it could be a gallbladder. You have your right lobe of your liver. So then you move over to your left upper. If you notice, we're going off the patient's side, right? So that we always go off the patient's left or right. So here's all these different things that we want to we don't want to poke, but we slightly with 2 fingers just want to press on the area to have an idea of what's going on. Note any pain, tenderness, that would be your decap BTLS and your not your AFPU, but your sample history. Build a good sample before you start doing your full assessment on here. That will give us some ideas. All right, so these are kind of long, so unfortunately I do got to read them to you unless y'all just want to read them and it's going to be awkward silence for a hot minute, but I don't think y'all want to do that. So beginning with, an anatomy and physiology of the GI tract. I think this is important, so I added some good information, and I'm pretty sure it's going to help you guys out. All right, so beginning with the mouth and ending with the anus, the GI tract is responsible for the intake of nutrients. Thank you, Victoria. Appreciate that. For the intake of nutrients, water, and other raw materials the body needs to grow and maintain itself. So the teeth and the muscles of the oral cavity begin the mastication process using the teeth to mechanically break apart the food we eat. Obviously, everybody knows what that's going about. So we bring food in our mouth. Our teeth are going to break it down to where we can swallow it. Yes, we know sometimes it's not broken down small enough because that's where we get the chokes. Excuse me for a second. Apologize about that. So the teeth break it down. So that starts the entire process that we're going out through as GI tract. The saliva contains several enzymes to break down the complex carbohydrates such as starch. The tongue then maneuvers the food bolus posteriorly past the glottis opening, where it enters the esophagus, a muscular tube that rhythmically contracts to push the bolus towards the stomach. So it starts this whole process. All these muscles, I'm using my hands. I can't really see it, but I'm going to back up and show you here. So the food comes down, starts going through this process, starts working its way around to the small and to the large intestines. Then it's broken down with all the enzymes from the saliva, all the acid that's down in here in those large and small intestines. And eventually it works its way out down here to the anus. So that's the process that we're getting to. Chyme is released into the small intestines, passing through the pyloric sphincter, and is the first section called the duodenum. Additionally, enzymes are secreted from the pancreas and liver via the gallbladder to further extract key nutrients from the chyme. Most of the water is absorbed through the intestinal walls and back into the bloodstream. Microvillus blurred inside the intestinal tract absorbs the nutrients. Over a period of 8 to 12 hours, the slurry becomes increasingly more solid, collecting into the large intestines. Most of the remaining water is absorbed, and eventually the anal sphincter releases the feces from the GI tract. So, from the time that you eat something, it takes about 8 to 12 hours to fully process the body, get moved through, and now it's potentially going to exit the body, let's say 12 plus hours. Then we get into the issues to where they may have like a colostomy bag to where that process does not work and it has to leave the body in another way. So it's a surgery process that they go in there and basically reroute your testes and just put to where it dumps. Obviously, I'm sleepy for some reason. I started realizing all of it now. And then it dumps an entire process. But the normal route and process takes 8 to 12 hours. All right, so here's 5 GI emergencies EMT should know. Now, here's a question at the bottom. If y'all want to go ahead and read it. So we have GI bleeding, peritonitis, acute mesenteric ischemia, bowel obstruction, and pancreatitis. What can y'all tell me on each of these? Can anybody tell me anything? Bueller. Sorry, I'll stop. All right, Travis. I want to know if y'all can tell me what each of these are. Each of these 5, can you give me any ideas of what they are? And it's 5 GI emergencies EMT should know. I know y'all see my mouse running around. I'm sorry. All right. So
well, I know a GI.
Bowel obstruction would be.
Keep talking.
I'm sorry.
Listen.
A bowel obstruction is when you can say they're constipated, and a GI bleed is a bleeding in a GI tract.
That's
what I've been asking. Come on, don't get my charge.
All right. So listen, just so y'all can have an idea, guess what we finna talk about? Guess what we finna go over? All 5 of them. Ta-da! So, because these are important to us, so we want to make sure you know them. So the GI bleeds, there's several causes for for bleeding in the GI tract, including peptic ulcers, local erosion around the muscle lining, gastritis, it's inflammation of the inner stomach lining, esophageal varices, swelling of the esophageal veins secondary to liver disease, and cancer. All right. An especially dangerous condition is a Mallory-Weiss tear that occurs when the esophagus or stomach. These can occur after several vomiting, forced coughs, or seizures and is associated with excessive alcohol use. Depending upon the size and location of the tear, bleeding can be minor or massive, requiring immediate surgery. Blood, if vomited by the patient, can become significant airway obstruction, especially if the worsening hypovolemia causes a reduction in the level of consciousness. That's a lot. So what we're going to break it down is to, if there is a tear in here, and that needs to be addressed pretty fast, any time of upper bleeding or lower bleeding needs to be addressed by a medical facility on the quickness. We don't need to delay anything. We don't need to wait around. We just need to make sure that this is taken care of. Now, if it's a continuous process and they continue to bleed, like it says right here, if the blood becomes significant, and it can be an airway obstruction. So if you have to suction often. So with them consistently losing blood, their level of consciousness is going to go down, okay? So that's why it says that. I gotta find my mouse again. All right. So acute blood from a slow bleed is a gastrointestinal tract, cannot be seen by the eye of the patient's faces and can go undetected for some time. In the patient's feces and can go undetected for a long time. A fecal acute blood test is used to determine if there's blood in the feces. So let me tell you how you do that. If they bring a trauma patient into ER, it doesn't matter what type of trauma, they're going to stick their finger up their rectum and they're going to swab it on this little bitty paper-like substance. What they're doing, that's what they're checking for feces. That's the blood in the feces. That's what they check automatically. All right. So obvious or frank blood in either feces or emesis indicates more rapid bleeding is taking place. Blood that is very loose or bright red in color indicates bleeding happening closer to either end of the GI tract. So hemorrhoids are examples of bright red bleeding from the veins surrounding the anus and lower rectum. Blood that has been sitting in the GI tract long enough can be particularly designed by the various GI enzymes, and acids is darker in color, which is going to be very dark red, and can take a tar-like appearance in feces or coffee ground textures and emesis. There is a unique odor with GI blood resembling a mixture of metal and rotten eggs. Whoa. I don't know how to tell you all that. Other than that, just you'll know it. As soon as y'all walk into home, nursing home, wherever, and y'all come across this odor, you're gonna be like, "Oh Jesus, what is that?" And guess what it's gonna be? Your patient. Your patient is the one that you have to deal with, and that you now have to figure out how to control your face and not all over the place as you're trying to take care of this patient. So remember, your face says everything. If your face says, "Oh my God," they're gonna know. Well, they can't help it. Yeah, Victoria, it's gross. It's I've seen several people vomit. Correct. You want to, if you can put the patient, if it's a lower GI and you can put a diaper on them, that's great. If you can lay something on the stretcher to contain it, it's great. But it's I'm not trying to make fun of nobody, but it's gross. GI bleeds can happen after a stroke. Yes. They can happen after seizures. They can happen after several incidences that you're going to see. So be very cautious of that. Again, watch your face. Like a large red bio bag on the stretcher. Sometimes I know this is ugly. I want to put them in it because even the little exhaust on the ambulance is not enough to keep up with it. Okay, so moving on. All right, so if the GI bleeding is significant, the patient can initially appear in compensated shock and may require fluid resuscitation. A patient may have orthostatic and posterior vital signs variation. When a patient is moved from the supine to standing position, there is a change in blood pressure or pulse consisting of one or more of the following. So you will have a decreased systolic blood pressure of 20 millimeters of mercury or more, a decrease in diastolic blood pressure in 10 or more, and an increased heart rate of 20 beats per minute or more. So to me, that is very important information because you need to check that. If you have a patient that is having a GI or abdominal pain, you need to check those. You need to check a seated blood pressure and a standing blood pressure. Because if there's any change in that, at least that, an increase of the a decrease in the systolic and the diastolic, that needs to be noted in the first place. Robin says, I experienced it firsthand, and I was like, "What? Oh yeah, I know." And it's always the best thing you can say is, "That's out of my scope of care. Can you please clean the patient up before we leave?" Hold on one second. Robin, I thought my husband was dying. Whew. It's how you say it? It's bothersome. How about that? It freaks us out. We don't really know what to do, but then everybody's like, it's your patient. What are you gonna do? And then you just kind of be like, okay, let me swallow my treat them the best way you can. You know that if they're losing it, they need it back. So if you can call for an ALS provider, it'll help you out tremendously. All right, so field treatment for GI bleeding is support. Maintain airway patency for patients who may be vomiting large amounts of blood. Position them for suctioning. We don't want to lay them in a 45. You want to set them up to a 90 degree if possible. And then you want to be able to have suction already ready. Don't wait until their second, third, fourth vomit. You need to have everything hooked up. All you got to do is plug and play when it's time to go, because you're going to need it. And when they start having these coffee grounds that come up the GI tract, that's just as bad. Okay. So just remember that have it ready, it needs to get ready to go. So an advanced airway may be needed to minimize aspiration if basic procedures fail. Patients who present in shock may need rapid fluid resuscitation in large amount to maintain perfusion because they're losing it. We need to put something back in. Large bore IVs, short length catheters should be used to deliver volume quickly. So if anybody knows much about needle size, I want to go as big as possible, and I possibly want to do bilateral IVs. Crystalloids such as normal saline or lactated ringers, and you may just hear LR, should be administered in a 3-to-1 ratio, replacing each milliliter of blood with 3 ml of fluid. Why do we want to say it that much, the 3-to-1? Does anybody know why? I know that's completely out of y'all's spec, but think about that for a second. Why would we want to do with a 3 liters of replacement of fluid versus 1 liter of blood? Anybody? So this is your free time to talk, and y'all aren't taking it. To help the blood get... All right, so I understand where you're going, Travis.
What was the question?
So the question is why do we do a 3-to-1 ratio of crystalloids as normal saline and LR versus for the blood loss? If we're losing 1 milliliter of blood, why do we replace it with 3 liters of crystalloids?
Because your body needs more fluid. It needs the fluid instead of, like, you're trying to replace the blood loss, the fluid, not so much the blood.
Correct. So the fluid is what we need to replace because the volume is missing. We need to replace because there's LR is a how do I say it? It is it has the viscosity of blood, but it doesn't have the nutrient holders. That makes sense to y'all? So blood has all the nutrients we need. We want to keep the red stuff in us, right? Well, LR is the best thing that we can carry in the field as ALS providers besides true blood. Once we get the true blood, then we can start replacing them, but we're playing a catch-up game. If they're losing 2 milliliters of blood every hour, we should be supplying them with 6 milliliters of crystalloids to help with the volume. Does that make sense to y'all? I know that's really off the beaten path, but I just want y'all. LR has electrolytes for your body. It has to be correct. Yeah, and I know that, like I said, it's way out of the spectrum for us to go over, but to me, that's important on why, if y'all are helping your medics out and you're setting up your IV bags and your fluids, on which fluid to grab, because your normal saline is let's put it this way, is drinking water. Okay. So your LR is lactated ringers, but it has a thicker viscosity. So it's like drinking versus water to chocolate milk. Kind of makes sense, I hope. So if it's a traumatic event and there's a massive blood loss, we want to hang LR. But if we don't have LR, that's okay. We can hang normal saline. Right, Victoria? It's thick like blood. In theoretically processed, yes. I just wanted y'all to kind of dab into it real quick, let you know what was going on, and then we'll bounce off. So I'm finna bounce off because I don't want to get too deep into that. All right. So we talked about GI bleeds. Does that make it a little bit better on? It's not gonna help you deal with it your first time, I can promise you, because you're gonna be, I don't know what I'm doing. So just remember that that's coming. Now, does anybody have any questions on GI bleeds? They can go lower or they can go upper. So y'all remember that. Lower GI bleeds and upper GI bleeds depends on where the tear, the cut, the blood loss occurs. If it's higher to the esophagus, it's coming out the top. If it's lower and been set in the stomach because gravity has stepped it down into the stomach, you're going to get a lower GI bleed. They're both gross, they're both important, and they need to be transported to a medical facility pretty quick. All right, we're going to move right on. Peritonitis. All right, so the peritoneum is a membrane that lines the inner line. Let me start over. It's a membrane that lines the inner wall of the abdomen and covers most of the abdominal organs. This lining can become infected with bacteria or fungi, causing peritonitis. In turn, this can cause a life-threatening sepsis if untreated. We all know what sepsis is. We all know that being in septic shock can kill somebody. So the severe cause of peritonitis, liver disease, can cause a buildup of fluid in the abdominal cavity. This fluid can become infected. Nice little trick for smells if Vicks vapor rub inside. Oh, very, very true. So if you know that you're going to a nursing home and you don't do smells, and I don't want to say nursing homes, if you go to a call and you don't do smells, you need to keep Vicks vapor rub it's just as important as carrying a pen. You want to keep your Vicks. Rub it just right on the inside corner of your nose. And now, since we all have to wear these cool, nifty little masks, you can rub it up in there, and all you're smelling is this nice menthol smell, and your face stays like your face is going to melt off because all you can smell is menthol. So that's very, very important. Thank you, Victoria, for bringing that up. All right, so we talked about that. So the patients receiving peritoneal dialysis due to kidney failure can introduce infection into the abdominal cavity. Rupture of the GI organ, such as an appendix, stomach, or diverticulum, a weak spot or sac in the intestinal wall, can introduce acids, enzymes, or bacteria. Other conditions include pelvic inflammatory disease, which we'll hear it's PID, pancreatitis, and Crohn's disease, and that's a chronic inflammation of the intestines. My mom had this, Crohn's disease. It wasn't debilitating, but it did kind of slow her down. They do have some medicine out there these days that can help with this. Some of it is treated with just adding some bacteria back into your diet with like yogurt and a few things like that. But Crohn's disease is once you get it, you got it, and you have it forever. All right, peritonitis generally starts with a vague signs and symptoms such as loss of appetite, nauseous, and a dull, aching feeling in the abdomen. So the discomfort can rapidly turn into severe pain that is constant and changes with movement and palpitation. Fever can develop along with vomiting, chills, and aches. Urinary frequency and amount diminished, as well as bowel movements. In severe cases, peritonitis bacterium, which is infection of the blood, develops and can cause sepsis, affecting the entire body. Septic shock can be fatal and requires rapid identification fluid replacement, and possibly the administration of vasopressors such as dopamine to maintain perfusion to no, it's going to require. I'm just going to tell you right now. It's going to require. Pain medications may be administered to provide comfort and care of some EMS systems authorized by their to each. Some agencies you can do antibiotics in the field. I carry several antibiotics out in the field of offshore. So that is one of those that, yes, I can do that, but it has to be very, very maintained, and it's a lengthy process to get approval for that. So as you see here, the big part of peritonitis is watching out for shock. If they recognize it early enough, they can help prevent that. But the signs of shock and septic shock is what we're looking for. Now, you may see somebody that's been sent home that may have this, and if you realize, be like, wow, I think their body's in shock because they've recently had a surgery or recently new to dialysis or a change in medical charts, a medical history because of a recent surgery, dialysis, infection, anything like that can create these. All right, so now bowel obstructions. I'll tell you straight up firsthand, I had one that hit me out of nowhere. Didn't even notice that I didn't go to the restroom for like 2 or 3 days, but I mean, it put me down hard. I wish I could hear my wife. So I went to our local hospital, told them something's wrong, something's not, like I don't feel right, and it really hit me within 3-4 hours maybe of severe pain. So as I'm in the ER, they're giving me pain medicines. Well, parts of me have quit acting like a big old wussy, and then parts of me started being the paramedic. Well, as I'm laying there, and I knew the nurse, I knew her very well. I knew that she was phenomenal. I knew that she knew what she was doing. So I had all out trust in this lady. But in my head, I'm sorry, y'all. Give me a second. I'm trying to change. Just a dot will be good. Victoria, can you hear me? All right, good. Okay, so I'm in there. Well, she gives me pain medicine, and unbeknown to me, I started hurting. In my head, I'm saying 1,000 times worse. And it may have been brought on because I was being a pansy at the time. But so if you know anything about medications, and I'm not going deep into this, but morphine is a smooth muscle agitator. Even though it's a pain receptor medicine, it made the medicines 10 times worse, the pain, because of where it was located. Well, I didn't realize that till probably the second one. I had probably 8 milligrams of morphine, and it made my pain probably triple. And finally, I look at the nurse and I'm telling her, "Don't give me that. It's morphine. It's a smooth muscle agitator." And she was like, "Oh my God." I completely oh shit. So, ended up getting fentanyl, which fentanyl is, it's amazing. I loved it. NG tubes, I had probably 600, how much cc's did I have taken out? I don't know how many cc's I had pulled out, but I had 600 cc's yanked out of me. They sucked it out from my nose in less than an hour, and I was instantly started feeling better. But I can tell you, from being a care provider in this world, in this industry, having an NG tube opened up my life, because I'm gonna tell you, that was the most uncomfortable shit I can ever say that I've had in my body at one time. And it wasn't going down easy. It was very rapid. She didn't give me no time. She was like, "All right, Chris, you know what's supposed to happen. Here we go." Lean back for me. And it was like, oh my God. Correct. Literally shit out my face, Victoria. They were literally sucking it out my nose. I know y'all are laughing. You're probably giggling at me, but I can tell you. So bowel obstructions are serious. They serious business in the house. Yeah, they were telling me if they couldn't get it with the NG tube, they were going to have to go surgically, and I was like, no, turn that pressure up. Let's get this out of here. Victoria saying my friend's brother just passed away to a bowel obstruction that ruptured while he slept in his and was vomiting his own and he was vomiting his own feces. So sad. Yes, it's very, very, very painful. Victoria, pain meds also can constipate the hell out of somebody. Yes. Christmas night 2020, man. I'm gonna tell you, 2020 was hell for all of us. But I can promise you again. So when I talk to somebody and they've had bowel obstruction, we don't play, bro. We gonna give them fentanyl, and they gonna feel comfortable in my world. So we're going to go over the bowel obstructions like everything else. The intestines can become partially or completely blocked, causing the contents to back up and cause inflammation. It'll come out your face, just FYI. The blockage may be results of tumors, adhesions within the intestinal walls, foreign bodies, or impacted stool. Hint, that's what I had, which is a large lump of feces that becomes stuck. Never had that happen in my life. This results in abdominal swelling, like I had a watermelon in my belly, pain and cramping times 100. The patient may experience severe constipation or diarrhea. Vomiting is likely. Nope, didn't have that. And severe cases obstruction, and patients may experience fecal vomiting. No, they just sucked it out of my face. Another cause of bowel obstruction is known as a paralytic. Paralysis is a dramatic slowing of the normal peristaltic motions of the intestines. So basically, your intestines go to sleep, and that's common. That's a very common thing for people to have. Is your intestines just go to sleep, and the reason why is from recent surgeries. What else they tell us? A lot of mine probably were from my migraine injections. Narcotics overuse will cause your intestines to go to sleep. Recent surgeries. They've asked me if I've traveled from another high altitude area to our altitude. So this can be caused by bacterial or fungal infections, Ischemia, appendix, kidney or lung disease, and certain medications such as narcotics. I'm not a narcotics user, I can tell you that. So it's bad. That's all I can tell you about bowel obstructions firsthand. It's bad. It's really bad. Most cases of bowel obstructions, they're not life-threatening. I thought mine was. However, necrosis of the intestines at the site of the blockage or perforation can develop, causing systemic infection, sepsis, and possibility of a septic shock. Once I really knew what was going on, I was more nervous because, unfortunately, I know these things. I knew what was, I guess you can say, what was coming, but at the same time as I was scared from what was going on. Kids, family, of course, all this comes in your head, you start freaking out. But that's that. All right, so pancreatitis. So the pancreas is located posterior to the stomach, deep inside the abdominal wall. As described, the digestive function of the pancreas is to form digestive enzymes that break down carbohydrates, proteins, and lipids in the intestinal chyme and secrete them through the pancreatic duct into the intestines. It also has the function of forming the hormone insulin used in regulating glucose levels in the blood and cells. Pancreatitis occurs when the pancreas becomes inflamed, usually caused by gallstones, clumps of cholesterol, and pigments leaving the gallbladder and blocking the pancreatic duct, or heavy alcohol use. Other causes include infections, cancer, trauma, surgery, and certain metabolic disorders such as hyperglycemia. I ain't gonna try to pronounce that one. I'm gonna make a fool out of myself. We just gonna let y'all read that last one. All right, so patients with acute pancreatitis will experience pain that is usually located in the upper abdominal quadrants, which would be your RUQ and LUQ, if you follow what I'm saying, right upper quadrant and left upper quadrant. The abdomen may be tender to palpitations, and the patient may experience nausea and vomiting. Some patients will report a close association of pain with food intake, especially food with a high fat content. Pancreatitis is usually not immediately life-threatening. However, it can become infected, which can lead to sepsis. Everything you notice is septic. Everything is going to kill you in your stomach if it's not treated. It can also become pseudocyst, fluid-filled pouches to form in the pancreas itself. These can burst and can cause infection. Severe pancreatitis can result in serious systemic inflammatory response syndrome, causing high fever and systemic shock. All right. I got one more after this one, and it should be almost time for a break. I know y'all are thinking, geez, that's a long hour. All right. Acute mysteric ischemia. Although rare, a drop in blood flow to the mysteric arteries can result in ischemia, injury, or infarct to the intestinal tract. This may result from a sudden blockage via a thrombus or an embolus, and a dissection to the superior systemic artery, or a systemic hypertension. Patients most likely feel a rapid onset of pain that becomes quite severe, as well as nausea, vomiting, and diarrhea. Depending on the location of the arterial block, large sections of the intestines may infarct and die, requiring surgical removal and resection of the bowel. If left untreated, gangrene, tissues decompression. Sorry, I was trying to make sure my kid's not going to get killed over there because my wife and her are doing homework. Whew. So it may occur, resulting in sepsis or septic shock. All right, so I know y'all like this one. This is not the end of the class, but we're going to stop going off what I want on there. All right, finally, most gastrointestinal disorders are not immediately life-threatening and require routine monitoring and transport of the patient from the field to the hospital. However, in a few cases, identifying the significant GI problems and providing initial care may help improve the changes of the recovery for the patient who is experiencing true GI emergencies. Whew. So, back to this one. These are the 5 things that you need to know about what's going on. So, y'all give me just 1 second. All right. So these are the 5 emergencies that we should at least try to have an idea. You're going to automatically know if it's this one. I promise you, your nose is going to tell you if it's this one right here. The bowel obstructions will also tell you, hey, how long has it been since you had a bowel movement? Well, I didn't know. I don't know. I don't keep up with that. I don't keep my daily poop log. So those are the things that can help you. Pancreatitis, if you build a good enough history, a lot of these may point out to you, let's say recent trauma, surgeries, alcohol abuse, anything like that, long stays in the hospital, have had a history of a GI bleed, or I've been treated for, I just had recent surgery of my liver. So those things right there can help you build a better idea when it's, there we go. So these will help you build an information, your chart when you start writing reports and all that stuff. It will help you over time just asking these questions. All right. So I know this picture kind of sucks, and I'm sorry. I tried to, even when I made it smaller, it just wasn't any better. So we're going to go over this, kind of get you some ideas of how it works again, what's in the quadrants. I know we showed the picture a while ago. So here's our oral cavity. Your uvula is a little baby ball that hangs right there. Then you have your tongue. All right. So here's your salivary glands, your parotoid submandibular, and then your sublingual one. So these are important because this is what produces the spit. The spit that's in you, that's for you to make the digestion of your food. Y'all tell you what, give me just 1 second, guys. I need to double check something. Just pause for a second with me. All right, so back to this. All right, so once you get your food broken down and your teeth have chewed it down enough to where your saliva starts breaking it down, then it goes down your esophagus. Once it gets in your esophagus, it drops into the stomach, and that's where all your enzymes, that's where that does the food breakdown. Once you drop the food in there, it sits there for a couple of hours and breaks down, starts becoming a little all liquid. The enzymes start separating. The nutrients are pulled out. Your gallbladder does a little bit. I don't have a gallbladder anymore, and I think they're the most useless thing in a human body. That's why they remove so much. So that sits right here. That'll also feed off into there, and that's where you get some of the gallbladder bile. Is some of the things in there. So that's part right there in that section. Even though you can remove those, trying to respond to a message. So then we're going to drop it back down in here until you have your liver. Some of us have, throughout our times in our life, have abused this a little bit harder than others, and but that's where your liver is located. We'll go down some more. Then it drops in here into your where your pancreas is. You have your colon in here, your ascending, transverse, descending colons. All of this, it's got to make it. I'm sorry, it drops it down into here to the small intestines. I'm sorry, I got lost completely, and I'm sitting here talking about it. You have your duodenum. We'll talk about this a little bit further in a minute. Your jejunum and your ileum. That helps break all the food down in here into your small intestines, and then it goes into your large intestines. I apologize, I got it backwards back here. So we talked about all this. Here's your appendix down here. Some people have them, some people don't have them, but that's the process of. And then it breaks it all the way down here, and eventually it comes over here to the anus, and we just get rid of it. We don't need it anymore. We've gotten everything out of it that our bodies can use. We've made it as clean as possible for us to move on and continue to get rid of it, because it takes. How long does it take before for food's completely broken down and passed through the body? Somebody guess. I hope you don't have to guess. I hope you remember from us going over it a second ago. 8 hours. I'll take that. 18 hours. I'll give that on the long end too. Y'all are both great. We'll do dash in the middle, and it's 8 to 18 hours. I'm perfectly fine with that. Moving along. Sounds like y'all are paying attention a little bit. All right. So back to some of the stuff the book puts in here. The gastrointestinal system is responsible for digestion process. Digestion begins with food is put in the mouth and it is chewed. The saliva gland secretes saliva and begins to break it down, like we talked about earlier. Food is then swallowed. Food travels down the esophagus to the stomach, and the stomach is the main organ of the digestive system. Y'all might want to remember that one. I'm pretty sure y'all gonna see that again. So gastric juices break the food down. So we showed you into the stomach where it dropped it in there. But y'all can't see my cursor. There you go, right there. I'm gonna knock on the table. Y'all might want to learn that one. Next. All right. So the liver assists in the digestion. It secretes bile. It aids in the digestion of the fats. I guess mine's a little bit slower because I'm a little bit thicker. I'm gonna say that's what the problem is, but I do like food. So it filters toxic substances produced by the digestive system. It creates glucose stores, so that's really important to the body. That helps us because if we didn't have that, we'd all be diabetics and we'd all need insulin. would all be having injections. It produces substances necessary for blood clotting and immune functions, because if we don't have that, then we're just going to bleed out. We need to have that, the blood clotting parts. So our bodies need to function through all that. And then the gallbladder is a reservoir of bile. So it dumps into the stomach as time. So that's the acid that helps break the food down. Again, some of us do have it. Some of us don't have gallbladders anymore, and it's okay. Your body still functions. It's very painful when you start to realize it's time to have that out, but we don't need them. That's one of the ones that they can remove, and you don't have to replace or take any medications. So your small intestines, your duodenum, is digestive juices from the pancreas and liver, and they mix together. The pancreas secretes enzymes that break down starches, fats, and proteins. So the pancreas also releases amylase, amylase. Y'all might see that one too. Amylase. So they're responsible for breaking down starches into sugars. Bicarbonate is also produced in the pancreas. Let's see. It neutralizes stomach acids in the duodenum. Insulin is also produced in the pancreas. I'm going to say y'all want to write that down, highlight it, do whatever you need to do to remember that one. That's probably important. I got to see where I'm at on my notes. All right. So it regulates the amount of glucose that we dump into the body. So the pancreas is very important. The duodenum plays a major role in absorbing the digestive products, and it does much of the work in the small intestines. So if you will look back over your pictures, I don't know if here, right here. So you see it does all the movements here. So it helps move the food through the small intestines. Your duodenum up here is what kind of opens and closes and dumps the food down into the small intestines. And then we'll talk about your ileum in just a second. But so your duodenum is what helps move everything around and gets the food through there on a proper process. So it's kind of important that we have that, because again, remember, all this functions and happens with our body, our brains. We ain't got to think about it. It just does it. It's probably why we sleep, unless y'all are inverted and you're on a nighttime program, and you does it while you sleep still, but it's a different form, like the regular of us. So there it is. Your ileum is absorbs nutrients that are not well absorbed. Absorbs bile acids so they can be returned to the liver for future use, and vitamin B12, making nerve cells and red blood cells, which the B12 is what kind of helps us get energy a little bit. We want the red blood cells that can help produce red blood cells. So now you see it's very important of what our small intestines does for our body. When it talks about, so it removes the liquid and it sends it back to the liver. So we're not trying to figure out, oh God, now we got to replace the enzyme that just broke it down. Okay, what are we going to have to eat or drink or swallow, ingest, however you want to get it in you, to replace it back so our food can be broken down into our stomachs? We ain't got to worry about that. That's already done, because it already pulls it out and puts it back into the liver for us to continue on and rock on to the next one. So the gastrointestinal system, the colon, is part of the large intestines. Food that is not broken down, it goes into the colon. Peristalsis moves the waste matter through the intestines. Water is absorbed, and the stool is formed right here in the colon, and it passes through the rectum to the anus and is defecated. So everything that we got, it's got to go through the colon. If you have colon cancer, you may have some issues. You may turn around. That's where we talked about. You may have to get the that holds everything to the side, so where you may have to live like that. Sometimes they can redo those, and you go functioning back to normal. I'm gonna hit this last one. It'll take us a minute, and then we are gonna take our breaks like normal. So your last one is the spleen. So the spleen is located in the abdomen, but it has no digestive function. It ain't got nothing to do with it, but it's down there, it's in the way. The spleen is a part of the lymphatic system. The significant role is related to red blood cells and the immune system. So it helps hold those blood cells and it pushes it back into the body when needed. And it assists with filtration of the blood, acids, and the development of red blood cells, serves as a blood reservoir. So, yeah, we can put some there. So, if your spleen ruptures, bust, and all that, you can bleed out internally. So, it's important that we get that fixed. If they start having issues, they can remove them. I got you, Daryl. And then it produces antibodies. So that's important. So if you ever have to have your spleen taken out, or you may have to supplement with like some vitamin D3 that's taken over the counter, which is very good. I know that my wife and I took that pretty hot and heavy when I was working overseas. It helps with creating uh, antibodies, and I took it a lot when I was in Afghanistan and Iraq, and I'm gonna say it helped me not get sick over there. But I still take some to this day. I don't take nearly as much because of being at home and exposed to a few more things. But that is also something that they may turn around and update it a lot higher. Um, we're going to take a 10 at this point because we'll start over the genital systems and chapter 18 of the book. Lessons he teaches is a bit different. Hey, and I promise you, I'm on the right one now. So I know y'all laughed at me last time we were all doing this and I was on the wrong chapters and all that. I promise you, I got everything downloaded correctly and I booted off all the other stuff. So it is chapter 18. I know it is a tad bit different, but again, I don't have a book in front of me, so I wish I could keep up with y'all and tell you a little bit more information. I will see y'all. Let's do the 7:10. So that'll give you 12 minutes to take a quick break, go do what you need to do, and come back, and we'll see you in 12 minutes. All right, see y'all in a little bit. All right. Hope everybody has take their 10 minutes. Maybe got some food, some drinks. I know my kids now are coming sitting down at the table with me eating spaghetti, so I'm kind of like a little jealous here. All right, get back to going over everything. I don't know exactly how many more slides we got left. My screen says one higher than another, but we'll go off a little bit later. We'll go where my mouse is, click the right button. All right, so we'll go over the genital system. So the male reproductive system includes the, hold on a second, let me read this over. So the genital system, the abdominal space also holds reproductive organs. Male reproductive systems includes the testicles, the epididymis, the vastia differentia, seminal vesicles, prostate gland, and the penis. And then the females is the ovaries, the fallopian tubes, the uterus, cervix, and vagina. The urinary system controls discharge of certain waste materials filtered by the blood and the kidneys. The kidneys are a solid organ. Remember that? Are a solid organ. The uterus, the bladder, and the urethra are all hollow organs. There are 2 kidneys, one on each side. That's the reason why you always say don't kidney punch them. They get too hard. I've noticed somebody's been in a car wreck, they've been hit too hard in the back, and they pee on themselves. So just remember that. Lie on the posterior muscular wall of the abdomen behind the peritoneum and the retroperitoneal space. Man, I'm gonna have to catch up on my words, man. I'm glad I'm not playing Jeopardy over here. All right. The kidneys play an important role in the regulation of acidity of the blood pressure. They're rigid to the body of they rid the body of toxic waste, controls balance of fluid and electrolytes, and the blood flow is high in the kidneys. So the blood flows hold a lot of blood in there. All right, so back over this one. The urethras join each kidney in the bladder. They are small, hollow muscular tubes. Peristalsis moves urine to the bladder. Let's see. The urinary bladder is located immediately behind the pubic symphysis. The bladder empties out into the body through the urethra. In the males, the urethra passes from the anterior base of the bladder through the penis. And in females, urethra opens at the front of the vagina. The normal adult, it holds about 1.5 to 2 liters of urine a day. Now, that doesn't include EMS, because we all say that we have the EMS bladder. Unfortunately, that's all we can hold no matter what. Once it gets to a certain point, it tells the body, hey, you gotta pee, you gotta pee, you gotta pee really bad, really bad, really bad. And then it starts getting worse. Yes, you can hold too much urine in your body, and you can have that effect, that it can affect you over time. Once you start urinating, it can get to a certain point and it just stops because there's still a reservoir of urine that's held into the body, but over time it does all filter out. So here are some cool little pictures of the kidneys, the urethra, the bladder, the prostates, the urethra opening, the urethra, the penis, and the external urethra opening. So now you understand how it flows. It's coming from the kidneys down the urethra to the bladder, sits right here, contains, holds it, fills up, passes around or passes through the prostate gland because it's going around the opening, passes through the urethra, the penis, and it exits that way. So then we start opening, we cut a kidney in half. So now you can see all the different pieces and parts. Everything from the kidney dumps down through the urethra like we talked about. This is not really on test questions in area, but I really like looking at things like that kind of break it down and I can understand a little bit better on how things work, how they function, why they do the things that they do. It just really, it makes me, I like the way that looks. So that's the reason why I do that. Let's see, I'm just flipping through here real quick on my notes. All right, next. So the pathophysiology, the abdominal cavity is lined by the peritoneum. The peritoneum also covers the organs of the abdomen. The partial peritoneum lines the walls of the abdominal cavity. The varicella peritoneum covers the organs. Man, they got me on spelling here today. The presence of foreign material, blood, pus, bile, pancreatic juices, amniotic fluid, and they all can irritate the peritoneum, causing peritonitis. So all those things that don't belong in there, it's kind of like a sensory muscle. It lets you know what's going on in there, and then it starts creating an infection. Acute abdomen refers to the sudden onset of abdominal pain, often associated with severe progressive problems. Peritonitis is typically causes ileuses. Ileus is a paralysis of the muscular contractions that normally propel material through the intestines. So that's its only job, is to push things through the intestines. So it's all like a muscle factory. It all works in lieu of each other, lines, and pushes everything through the entire intestines. The retained gases and feces called abdominal distension, which we all know where that goes. The stomach can empty itself only by vomiting. Peritonitis is frequently associated with it's associated with nausea and vomiting. It's kind of a telltale sign because it's only got to go one way. It's only going to go up. So we want to make sure we can try to prevent that if we recognize it early. Peritonitis is also associated with loss of bodily fluid into the abdominal cavity. The patient may present with tachycardia or hypertension. Look for signs of shock. That is the biggest thing. So look for the signs of shock there. If they start vomiting repetitively, you know it only goes one way. Diverticulitis is the inflammation of small pockets at weak areas in the muscle walls. You're going to see some fever with this. Cellulitis as a gallbladder inflammation, and fever may also come with that one. Acute appendicitis is the patient's temperature maybe with normal range. That's just a lot of these things that it's just one of those, man, what are we trying to do? There's so much stuff out there, and you want me to recognize this? I get it. I understand what y'all mean. It's a lot of stuff. We're just trying to give you a basis of information on things to help you build a case on how to treat your patients. So, talking about abdominal pain, this is where it's kind of cool to me. Actually, the whole entire class has been really cool to me. So there's two different types of nerves that supply to the peritoneum. Abdominal pain can have different qualities. I'm sorry, one second. The peritoneum is supplied by the same nerve that supplies the skin of the abdomen. So that's kind of cool. It can perceive pain, touch, pressure, heat, and cold. Can easily identify and localize a point of irritation. So they can literally take one finger and point and say, this is where it hurts. It hurts specifically right there. The nerves are far less able to localize sensation. Patients will not be able to describe exactly where the pain is because it's going to be referred. So that may be the site of injury is going to be able to tell if there's pain, touch, cold, or pressure. But when your patient is trying to give you an idea where it's going to hurt, it may actually be affected on one side of the quadrant versus the other. So it's confusing because it'll give it look right here on this next page. So these are your types of your nerves. So if it's your gallbladder, that it may hurt in a different area. You're going to have abdominal pain, but it's not going to be dedicated to the upper left quadrant. So that's where they're trying to tell you is the different types of pain and the synapsis points and all that. So this one is showing you that it may have shoulder pain, and it may have lower quadrant pain versus upper quadrant. So that's the reason why they're telling you there's two types of different types of pain. Causes of acute abdominal. You may have ulcers. The protective layer of muscles erodes, allowing acid to eat at the organ. So over time, it just eats itself, and now you're starting to pay for it. Causes of peptic ulcers. You may have your Helicobacteria pylori infection. If y'all want to spell this common spelling, y'all can write your notes down. That's common spelling on that one. Alcohol and smoking. If the erosion is severe, it can lead to gastric bleeding. Peptic ulcers affect men and women equal, but occur more frequent in the gastric population. Described as burning, gawing pain in the stomach that subsides or diminishes immediately after eating. Nausea, vomiting, belching, and heartburn are common symptoms of your ulcers. Some ulcers do heal without intervention, and sometimes they require medicine. Gallstones is the gallbladder is stores of pouch for digestive juices, like we talked about. It can help dump them back into the liver, help with digestion. Gallstones may form, and if the blockage does not pass, it can lead to severe inflammation of the gallbladder called celiocytes. It's a condition in which the wall of the gallbladder is inflamed and the gallbladder can rupture in severe cases. I think I know one person that actually had the rupture. I had mine, and then a couple of years after I met my wife, we were at a Mardi Gras ball, and a couple of days prior, she was like, "Oh, I'm hurting, I'm hurting." Well, the night of the Mardi Gras ball, if y'all have ever been to Mardi Gras ball, okay, well, never mind. She said she hurt for 3 months prior. She just didn't say anything until the night after the Mardi Gras ball. Nobody was really intoxicated enough to listen to her. But we went as soon as we got back to our house and realized that something was up. We ended up getting her checked out. She ended up having gallbladder surgery in a couple of days. So some of the symptoms of gallstones, they may appear 30 minutes after a fatty meal or at night when you're laying down. Some symptoms include nausea, vomiting, indigestion, bloating, gases, and belching. Victoria, to add on that, now y'all know what happens to the world when Mardi Gras is shut down. It freezes over. If y'all didn't notice, that's what happened to the ice storms because Mardi Gras got canceled. People are at higher risk for developing cellulitis include women, older adults, obese people, and people of Scandinavia, Native Americans, and Hispanic descent. I don't have any idea why you got to have higher issues if you're from Scandinavia, but that's what they say, and that's why I went and wrote it down. I couldn't find it. I couldn't Google on why, and it may be some of the foods that they ingest or the food that's around the area, but I don't think that's going to be a test question. So, pancreatitis. It's inflammation of the pancreas. It's caused by obstructions, gallstones, alcohol abuse, alcohol abuse, or other diseases. Some of the signs and symptoms you're going to have upper left and upper right quadrants. It's radiating to the back. We all know that when you start having back pains, and it's not just referred to a muscle, it could be your liver, your kidneys, all those things. But think about pancreatitis too. So a patient reporting that the pain is worse after they eat, you'll see nausea, vomiting, abdominal pain, abdominal distension, tenderness, sepsis, or hemorrhages may occur, and look for some fever or tachycardia. So when you check their vital signs, their heart rate may be into like the 120s, 140s. I don't think you're going to see SVT, which is supraventricular tachycardia, which is going to be a lot higher than that. But look for higher pulse rates and note those when you start doing your assessment, and go back to it and check it again. Appendicitis, inflammation or infection of the appendix. We all know that. It can cause tissues to die, causing abscesses or peritonitis or shock. Pain initially is generalized. Sometimes it's dull pain. You may see where they diffuse maybe in the center of the umbilical area, right around where your belly button is. So the pain later localizes to the right lower quadrant. I'm sorry. It's going to be more to the right lower quadrant. Some signs and symptoms of your appendix is nausea and vomiting, fever, chills, rebound tenderness. That's a big one. So when you're checking for the rebound of these hollow or solid organs, you'll notice more pain when you do it that way. And I'm going to show you all in a little bit on how to assess the quadrants. My daughter agreed to allow me to use her as a site here in a little bit. We'll do that in a little while. So we're going to check that by, let's see here. We're going to press down gently firmly on the abdomen. The patient will feel pain when the pressure is released. Let's see here. So gastrointestinal hemorrhaging is a bleeding within the gastrointestinal tract. It may be acute or it may be longer durations of less severe. All complications of this are considered serious because we don't know, we can't see it, we can't fix it. Bleeding in the the gastrointestinal tract occurs from the esophagus to the upper small intestine. Hematemesis is frequently seen in patients with upper gastrointestinal bleeding. Lower GI bleeding occurs between the upper part of the small intestine and the anus, and often manifest as milia or dark tarry stools. Again, you're going to know that. Give me a minute. All right, so give me just a second. I'm going to try to get my daughter over here and get it situated, and then I'll turn my camera on so y'all can see how we're going to assess the abdomen and what we're looking for. And it may take me a second to get the camera adjusted and all that fun stuff, so bear with me for just a second. Hold on, I'm going to put you on mute for just a second, and we'll get this going. All right, let's see. Hold on a second. I can't even see my screen. Give me just a second so I can try to figure this out. All right. Somebody turn your mic on real quick. Make sure y'all can hear me.
Yeah, I can hear you and see you.
Good deal. Well, this is my daughter. This is my daughter, Charlie. So what I'm going to show you is, if you'll see right here, so here's our quadrants, all right? So we're going to separate our quadrants. Maybe turn it a little bit like that. All right. So we're going to separate our quadrants, and it's going to stop and start right here at the belly button. So this is going to be your right upper, left upper, lower left. So it's LLQ and RLQ. So when I go to assess it, if she's telling me she's having pain right here on her left side, the way I want to do it is I want to take, I don't want to take my whole hand. I just want to take 2 fingers and I want to push. So if I don't have any when I push in, if I push out and she feels the pain, that's where we're going to go more towards the appendix, because it's a hollow organ, maybe not on this correct side. We know where our appendix is at. But when we assess the stomach, we're going to, and anywhere we're doing a GI assessment, we'll push down in here, we'll push in different areas, and don't go directly to another area. Give them just a second. And once you give them a second, then you go to the other area. Any pain down here, you want to assess it all right in here. Then you go a couple more seconds, and then do it again at the top. So if I'm hurting over here, we'll do that area last, because if I do it first, it's going to make this entire area hurt. Y'all see what I'm saying and understand? So assess the area of pain. If she says, I'm hurting right here, I'm not going to start there, because then I'll make the entire area start hurting. So I want to start down here and work my way around. So remember, if I'm pushing down in this area on a female, I may turn around and have, some rebound tenderness from the ovaries, because they're a little bit lower. So I want to keep that in mind too. What is really hurting? Am I hurting down here, or is a referred pain? Okay. So that just wanted to show y'all we're not going to take our whole hand and push on it. We're just going to take our two little areas, push around on our fingers, stop, wait a second, ask a couple more questions, go to another area. And you can feel certain organs in there when you push around. It's kind of got to know what you're feeling for. And just want to kind of give you all a visual kind of so you'll understand your quadrants and how they separate right in here. So you have to be careful on certain areas. If you're doing a female and it's just a double man crew, get some of that family member to come in there so you can check them correctly. And I'm not going to lower the pants to try to assess them. I just want to check in this area. Even if you have to palpate over the pants, that's fine. Just make sure you keep that in consideration, okay? So there's that. So give me just a second to get everything turned back around. All right, thank you. Well, there's my kids. Hang on one second.
So cute. What's her name?
That's my daughter's name is Charlie. So she is 100% her daddy. I can tell you. I don't know where my mic is. So my cursor has messed up on me real quick. So where is everything at? I have lost my cursor, y'all, so I'm so sorry here. Give me just a second. Guys, I don't know what I did. I'm trying to find my cursor, and I have lost my cursor. All right. Maybe. Is this going to work? All right. So now let me just find my notes on another side over here, and we can continue. As you tell, sometimes computers are not the best thing for me. All right, so I got it. Now we're back. We're good. Let me click back over to y'all's questions. All right, so the next one. All right, so going over the esophagus. I have to manually flip pages now instead of having it on my other screen. All right, so the esophagus, it's esophagitis, occurs when the lining of the esophagus becomes inflamed by infections or acids from the stomach. The gastro reflux GERD disease is a big one that you'll see in here. Gastroesophageal reflux disease. It's a condition in which the sphincter between the esophagus and the stomach opens and it's allowing stomach acid to move up into the esophagus. Sucks. That's really bad. It's also referred to acid reflux and can cause a burning sensation within the chest, as you may hear heartburn. So when you ask a patient, is it heartburn or is it some other problems? That's where you're wanting to know, because if you can be cardiac and or GI related. So a patient may report pain when they swallow. You may have heartburn, nausea, vomiting, or sores to the mouth. You may have some fatigue, and right here at the bottom, some weight loss, some jaundice, edema, or abdominal pain. So your Malinois syndrome tell you, I got to change everything. Hey, go back to this one. I want to talk about this one. So, esophageal varices occurs when the amount of pressure within the blood vessels surrounds the esophagus increases. So that's in part. That's very because what'll happen is it'll create tightness. The blood flows blocks parts of the portal vessels, and they dilate, which causes the squeeziness. You have massive upper gastrointestinal bleeding and hematocytosis, which is very gross because you can't fix it. It's a lot of bleeding, and you have to hurry up and rush to the hospital because we can't fix that out there. Some of the we'll see right down here. Some of the signs: fatigue, weight loss, jaundice, edema, abdominal bleeding, abdominal pain. Rupture to the varices is far more sudden. You have a sudden onset of discomfort to the throat, severe difficulty in swallowing, vomiting of bright red blood because it's higher on the esophagus side instead of down into the stomach. So it's got to come up instead of going down because of the sphincter muscle that's there. You'll have hypotension. Why are we going to have hypotensive? Anybody want to know about that? Anybody want to ask, question, guess, assume? I'm waiting. Bueller. And we'll also have signs of shock. So the reason why, so your pain is going to be very painful, but your hypotensiveness is because you're losing the blood. You're losing blood flow there. You're losing blood, so you're going to be hypo, which is low. So there, your loss of your consciousness level is going to decrease. You're going to be a little bit more, I'm not going to say combative, but more confused because your blood flow is losing. All right, so now we're back here to the Mallory-Weiss syndrome. So the Mallory-Weiss syndrome is a junction between the esophagus and the stomach, and it tears. It just happens to just rip. So causes severe bleeding and possible death. Some of the risk factors is alcoholism, eating disorders. It is prevalent in older adults or older children. Vomiting is a principal symptom, so very vigorous vomiting, like when somebody's trying to vomit from their toes, and y'all all know what I'm talking about, but it's so forceful that you can create that tear. In extreme cases, patients may experience signs and symptoms of shock, upper abdominal pain, hemiotesis, and so when we start vomiting so hard and that tear, it's not mistaken between a cardiac related issue tear. It's going to be very centered to the chest and the throat because you're going to have bright red bleeding, and it's going to be copious amounts. I'm not saying that they won't bleed out, but as you see, it can be fatal. But at the same time, as if it's caught early enough, and most likely we are because it's going to be super painful and it's going to be while they're vomiting, that you can transport them to a facility and it can be treated. It's not going to be treated orally. I mean, they're going to have surgery to fix that. So ponder that in the back of your mind. When you see this, is it GI related bleeding? I don't know, but still something any more than I don't want to. So it can be caused by non-infectious conditions, such as adverse medication reactions, some toxins exposures, some chemotherapy due to where it's located can cause the tearing. So here's some signs and symptoms of your Malin-Weiss or your gastroenteritis. You'll have large dumping type diarrhea for frequent to small liquid stools. So your quantity in versus your quantity out is not the same. That's where they're talking about the large. The diarrhea containing blood or pus, you'll notice that when they get up to go wipe or as they look down. Abdominal cramping, nauseousness, vomiting, fear, just because they're worried. They see the blood that's there. They don't know what's going on. They don't know how to fix it. It is painful. They try to figure out what's going on, and they're just like, I don't know how to fix this. Please help me. So their fear is increasing. You'll notice a change in your vital signs, but be cautious and not over triage this patient, but treat them for what you see. Treat your patients and treat them appropriately. So diverticulitis. You'll have fecal matter becomes caught In the colon walls, diverticulitis was first recognized around 1900, is when the amount of processed food eaten was increased. So versus processed food versus natural, what we grow outside, we wash it, clean it, keep going. We can kind of blame that to the processing, some of the stuff that they put on the food, MSG, a few things like that can cause that. Bulges in the colonic walls result in an increased intestinal contractions. Some fecal matter is caught in the bulges, and bacteria gather there, causing inflammation and infection. Ooh, sorry, that kind of got me. That's gross. So some of your main symptoms are abdominal pain on the left side into lower abdomen. You kind of have those people like, man, I'm just hurting over here, and then maybe it'll come and go. And it's only like on one side. It's very like you'll see them pushing on it because they're like, oh, I don't know what's going on. It hurts. Got to figure out why, and it's just constant. You got to figure, ask these questions, build that case up, helps you do your assessment. Nausea and vomiting is also associated with that. So hemorrhoids, I'm just gonna lay it out there. Majority, I'm sure some of you have dealt with this at some point in time in your life. If not, you know somebody close to you that has. So they are created by swelling of inflammation of blood vessels surrounding the rectum. They may result from a condition that is increased pressure on the rectum or irritation of the rectum. Increased pressure may be caused by pregnancy, straining to stool, and chronic constipation. Some diarrhea can cause irritation. You can have bright red bleeding because of the irritation and the vessels. The skin becomes thin in that area. Sometimes you'll have minimal bleeding. I've known some people that have bled pretty heavily because of the hemorrhoids. And patients may also experience itching and small masses on the rectum. It's a bumpy subject. Sometimes that they're right there on the outside, sometimes they're on the inside. They are painful, and then you'll notice a lot of people like, man, if they talk to you, man, I got a lot of itching. I don't know what's going on. And the first thing you're like, wash it, wash yourself. I don't know what you need me to do, but wash it. And it may just be a hemorrhoid. It's their first time to ever have a hemorrhoid, or so that issues to the rectum is very concerning. Give me a second. I gotta get me a drink. All right. So bladder infections, UTIs, those are all common. We've seen people that's had them. Y'all may have had them. You may have treated somebody, know somebody within the family. It's caused by bacterial infection. Most of them all have lower abdominal quadrant pain. They may report an urgency and frequency of urination. So they're like, man, I'm always peeing. I don't know what's going on. And then they have this, it becomes severe if the infection spreads to the urethra or the kidneys. So they may have some pain. They may also report just they're all the time going to the bathroom. So maybe when you recognize your UTIs there. So your kidneys, they play a huge role in eliminating all this waste. So we got to keep our kidneys. They're very important to us. So when the kidneys fail, urea results, the waste product. Urea remains in the blood. Kidney stones can grow over time, causing blockage. Some crystalloid chemicals in the urine. Blockage can lead to swelling. Pain is caused by the stone movement in the urethra, and as a stone passes on its own, or it can be surgically removed. I've known some people to have to go and have them electronically ruptured. They use sound waves. They'll use all these different little cool things they put you in the machine. You'll put like centralize a give me 2 seconds. Sorry, minor emergency. We're good. We keep going. So they put them in this contraption and they centralize these sound waves that go into around the kidneys to bust these stones up. Sometimes they can, sometimes they can't, and they may have to go in there and remove them by surgery. It's still painful, it's still aggravating. but they do happen a pretty good bit. So you can go acute knee kidney failures. Will have a sudden decrease in the kidney functions. It does occur from a hemorrhage, dehydration, trauma, shock, sepsis, heart failure. You all know somebody that's in the hospital for a long time can have acute kidney failure. It's very dangerous. Put them on dialysis. Can treat them those ways. Sometimes they are irreversible. They can't even bring it back. Sometimes it's caused by diabetes or hypertensions. The kidneys tissue, they shrink and the function just quits over time. They just say, peace out, I'm done. Eventually, dialysis or kidney transplant is required to remove the waste from the bloodstream. A lot of your symptoms, you'll have altered level of consciousness. You may see a seizure. You'll see them in comas. They'll be lethargic. Obviously, nausea, headaches, cramps, edema in the extremities. And the reason why you see all this is because it's not filtering the blood anymore. The blood is dirty. It's moving throughout the body. So that's where all this it comes from, where your body starts rejecting it and it fights itself. So they can go into a coma, and if due to the urine output, they start testing them and they see these things, so they may turn around and go ahead and put you on dialysis, and just to try to go around your kidneys because they know that they're not working. Sometimes, if you're lucky enough, you can get on the transplant page. If not, it's permanent, and you have to stay on dialysis and continue life that way. Some people have made a very, very long time being on dialysis. Sometimes it doesn't take long, unfortunately, for dialysis to kick in, and then the body just doesn't recoup from that. Your female reproductive organs. I know we're all grown people, and I'm sure we've all learned this at some point in time. So we're not going to hit this real hard. We're just going to go over it. We know majority of these are all in the lower quadrants. You may have, so right here, I see this now. Your lower quadrant pain may relate to your ovaries, fallopian tubes, or your uterus. We'll cover that more in depth when we go over the gynecologic. There's a whole nother chapter. It says right here 23. I don't know if one of y'all want to verify that, but in chapter 23 we'll discuss that more from what my notes say. When you go to assess these patients, you'll be able to they'll be able to tell you, oh no, I'm having, my reproductive organs, or like my ovaries are killing me, they hate me. And then our females, they get to endure this, monthly. But again, I don't think any of us men can handle that, so I'm going to leave that alone there. So the aorta lies immediately behind the peritoneum. Weak areas can result in an abdominal aortic aneurysm, which is a AAA. So a AAA is difficult to dissect, but it's not saying it's not impossible. When you mess with a AAA, you very, very cautious with this patient. Don't cause any quick movements, any jerking. It's like trying to transport that golden egg over a bumpy road. You want to go slow, smooth, and unfortunately, sometimes if you can recognize it being a AAA, you might as well just tell family just to get in the back of the truck and go with you. So if the aneurysm tears or ruptures, massive hemorrhaging may occur. They may have pain described as a tearing sensation. We said handle the patient with very gentle care. Sometimes pneumonia, especially in the lower lungs, can cause this. They'll also cause abdominal pain, but so hernia is also in the part of the organ systems here. Hernias is a protrusion of an organ or a tissue through a hole or opening to a body cavity where it does not belong. They just go wherever they can find the weakest area. Congenital defects such as around the umbilical can cause that. A surgical wound has failed to heal. I've actually dealt with this. A lady got discharged from UMC back in the long days ago when I used to work at AMR. Don't say nothing, Victoria. But the lady sneezed and she just had a rupture and her intestines popped out at Wendy's right across the street from UMC. And I was good over there. I was like, oh, Jesus, what is that? So it's just a small area. She was cool. We transported her right back to the hospital where she just got discharged. Um, Reducible hernias pose little risk and can be pushed back into the body cavity. Incarcerated hernias cannot be pushed back into the body and are compressed around. They're kind of enclosed with body tissues. Strangulation of an incarcerated hernia is a serious medical condition because it cuts off the blood flow. Blood supply is compromised by the compressed surrounding tissue. So if we don't want to cut off any sort of blood flow to the area, so if the faster we can recognize it, get them to a treatment facility and let them go straight to surgery is the best we can do for them. Because any type of hernia, if they know that they have them in their stomachs and all that, sometimes you can see them, large hernias in the stomach. It's a serious issue, and we're just there as a taxi, to be honest. Serious hernia signs and symptoms. A formerly reducible mass that is no longer reducible. Pain at the hernia site, tenderness, and red or blue skin discoloration over the hernia. And the reason why that is blue, because it is not oxygenated. It is not working. Red, you can tell by the infection. Like if anybody's ever seen when they've had something poked into their skin, the area around it gets really red, kind of short for a few couple minutes. And the reason why is because it's irritation, inflammation of the area. White blood cell counts are automatically trying to jump in that area and treat any type of infection. So you may see some redness to the area due to temperature, infections. That will start that way. And guess where we're at? Everybody knows what's coming. All right, so y'all can kind of guess from here. We're on the way down on our downhill side. I tell you what, since I don't want to stop and start as we do our scene size up back and forth with each other. Let's take just 8 minutes to the hour. I tell you what, just give 18-minute break. I need to step off and handle something real fast. So I will see you back at 10 after 8. If you have any questions or anything, hit me on the message. I will step away for just a minute, but I'll be back. See y'all at 10 after 8. All right, folks. I know y'all are super ready to get back into this. But this is the last little bit. If y'all paid attention from the last few slides, when we start our scene size up, we'll go over everything. Kind of gets into our last little bit. Before we start our scene size up, who's got questions? What do they want to question about? And is there anything y'all want to go over? I'm going to take that as y'all are pondering it. All right, so scene safety. We all know, wear your gloves, your gowns, your mask, uh, protective coverings for shoes. Could be required depending on what kind of GI bleed this is. Make sure you're specifically your mask with your your smell fragrance around your nose, as we reported back to that a while ago. So your MOIs, look for may result of violence. It's your pale, sweating patients that they say they felt a tear in their chest. That's the number one telltale sign for a AAA. You may have the smell, the odor of a lower GI. If it's upper, lower, unfortunately, you are going to have to look at it. That will be one of your signs. Is what's going on? How's it look? Um, how long ago did it start? That's some of the things that you're going to see there. Whoops, I hit the wrong button. Sorry, folks. That's on my end. All right, so your airway, if it's any type of airway, if you feel like you're going to have to suction because they keep vomiting, suction early, continue to suction often. That'll help keep the bloodway open. So the airway open so they can have adequate respirations and that they're breathing on their own. I mean, if they have to breathe off, if you have to breathe for them, ponder that idea that they may need ALS provider. You may have to stick an adjunct in their airway because maybe a king or a ET tube for a higher level of care because of it may be impeding their airway because of the blood flow that may be coming out. Circulation. Ask about blood and vomit and tarry stools. Has there any? What's there any? How long has it been going? And check for pulse in both arms. Also, highly encourage to check for pedal pulses too. Pedal pulses are very important to you make sure that there's blood flow continuing to the lower extremities. And then you transport. Are we going to be this? Is this immediate because there's significant signs of illness, or how much blood loss are we talking about? Just because you can take 10 cc's of blood, drop it on the concrete versus 10 cc's of water, it's going to look very different. So I wish that I'll talk to Rob about this when y'all do your boot camp, because it very does help. Even though you can see water squirt on the concrete versus 10 cc's of red food coloring water poured on the concrete, it looks like a lot more because of the color, the way that it sits out there. But blood's going to always look like it's a whole lot more. But take it for the way it is. So if you see a whole lot of blood on the floor, go with it and transport rapidly. Sample history is very important. Hey, has there been any much weight loss? Have you had a lot of burps? Are you passing gas? How much pain? Where is your pain? How often? How long has this been taking place? What's different from the pain tonight versus the pain yesterday? What makes it better? What makes it worse? Those are important questions to ask as you're doing your sample history, and you need to document those. Write them down. So what if you got to write them, on all over your glove? Pull out some tape, tape it on your leg, or get some paper and write all this information down. 4x4 pieces of paper are really good, but highly encourage using some sort of Sharpie, because when you start poking down on the pen, sometimes you can poke through the paper, and then on your 4x4 it makes it a little bit hard to read later down the road. So your physical exam, like I showed y'all on my daughter, is where to poke, how to poke, how to absorb it. How to perform it and all that fun stuff. Normal abdomen is soft, not tender. You'll be able to poke in there. Not saying that you want to poke with depth, but you can push pretty deep and it's not going to bother. Pain tenderness is a sign of acute abdomen area. Expose and obsess the abdomen. Palpate gently. If you can't see it, you can't palpate it. That's always been my thing. I need to see what I'm fixing to put my hands on. If you have to pull their shirt up, like I showed y'all with my daughter, you may have to do that so you can turn around and assess it effectively. Same thing with the legs. That's the reason why we say remove all the clothing during a traumatic incident. Now, be respectful to the patient. You may have to remove all their clothing, but at the same time, let's keep them covered because you don't want to expose them to the elements, the heat, the cold, and all that fun stuff. But you need to see it before you put your hands on it. Make sure it's there. So your vital signs: check respiratory rate, pulse rate, blood pressures. Get them stand up, seated, so they can get adequate blood pressures. Now, you're not going to check your left side at 8 o'clock and then the right side at 8 o'clock. If you need to check them within the minutes of each other, that's fine, but document why you're getting to do those pressures, because you should have a seated blood pressure on one side and a standing blood pressure on the other side, and compare those. And if there's any drop of, by 20 on each side is very significant. Your reassessment, you're going to reassess the abdomen pretty frequent to make sure that it hasn't changed. Is it still soft and tender, or is it pretty, distended and it's very rigid? The rigidity is there. Transport the patient to the most comfortable position. If they need to be on a 45, a 62 degree, just whatever you can get that stretcher in a comfortable position. You don't want to sit there and pat their head and rub their hair, but be supportive to them. Give them the idea that you're going to make sure everything's going to work out. We're going to get you taken care of, and just be that emotional support to this person, because it's just serious. Something's going on that they're not knowing. You cannot treat the cause of acute abdominal abdomen. Take steps to provide comfort and lessen the effects of shock. Treat for shock even when obvious signs are not appropriate. Low flow oxygen may decrease nausea and anxiety. I have seen over time, and I've started picking it up on my new thing. Some people say, oh, if you start an IV on me, I get really sick. Well, I got it from a friend of mine. They actually take a little alcohol pad and they stick it right there at the nose. What it does is the smell. I don't know, something about the smell of alcohol when you start an IV on somebody. I'm not saying the pain's not there from getting that quick poke, but it's helped a few that I've used that to. So that's just a little trick. It also helps with nausea, as Victoria just posted down there. So works good for nausea because it just, I don't know, it just does. That's the best way I can describe it to you. After releasing the patient, the hospital staff obviously clean the ambulance. Woo, woo, woo. Please, if you got to go down for decon, go down for decon. If you got to go change your clothes, that's fine, because you don't want cross contamination, all that fun stuff. Make sure that you just clean. Then take the time to wash your hands, wash your arms, get all those clean before the next call. Dialysis emergencies is the definitive treatment for chronic kidney failure. We know that dialysis filters blood, cleans the toxins, returns the body. It's a pretty lengthy process. You may drop your patient off at 5:30, between 5:30 and 8 o'clock in the morning. You may not pick them up till 6 o'clock at night. So keep that in mind. It's very lengthy. They do get cold. They eat there, so they're going to bring a lot of luggage. They're going to bring some stuff with them. Dialysis machine functions much like normal kidneys. I don't remember the name of the fluid. I just went blank, but it cleans the blood and just puts their blood right back into their body. Some adverse effects of dialysis: you'll see infection at the site. It's either they're going to have a PICC line, they have a central line. Sometimes it'll be in the arms. I've seen it in the neck. And it's going to be, over time, they'll have to have it changed because it just gets hard, occluded, and they're not able to function that anymore. So, and specifically talking about dialysis, if you're taking care of somebody and their left arm is where they ask them, do you get dialysis? Yes. Where's your port? On the left side. Do not take their blood pressure on that side. Always use it on the right side. Even if they are starting to have some other GI issues, do not take it on the side of their ports in. Do not. If for some odd reason a port bleeds, Victoria, you got my next point. They do rupture or something happens, you're going to basically have to put a tourniquet on there. You're going to have to occlude it with a tourniquet, secure it that way. It's something that's very important. You got to take care of things. And hold on one second, real quick. All right, so blood pressure cuff works great for stop the bleeding. That's correct. That does happen. So think about that. There's a little all those different things that are out there. You may have to use a manual cup. Victoria's obviously hollering at us. So you may have to use a manual cuff so you can pump it up and hold the pressure, or a tourniquet as maybe your last resort. Change. Manage your ABCs. We all know that. If they need oxygen, give them oxygen. Don't withhold the oxygen. Manage bleeding from the access site. We just talked about that. Transport properly. Don't stick around. Don't stay and play. This is something that we can't fix. They need to go get seen about. If they're having pulmonary edema trouble, you may have to sit them up. Other than that, you want to lay them down. If they need to be in shock, elevate their feet in Trendelenburg position. That may be very, very important. All right, listen, guys. I know there's not a whole lot of this chapter. It was very boring. It's not as in depth as the respiratory, cardiology, and the pharmacology. So we're kind of on a downhill side that we're kind of making things a little bit easier. Getting things on the easier. We kind of have to get the hard stuff out of the way. So the easy stuff starting now to go through. I will be posting some questions. I hope to get 11 that are in this class currently and the ones that are going to listen to it. So I would say I'm just going to go on a rough ball 15, 16 responses. I will post more questions this time. I will post about 8 questions for you guys to answer. So that'll kind of be your study. We will go from there. I did not get to post any from the last class, so that's the reason why I'm gonna post a little bit more this time. So we'll say 8 on the new roster for the new questions, and it'll all be on what we've covered tonight. I know that some of you guys have had some issues in the past with some of the questions on how they're worded in your quizzes. I've seen some of the quizzes. I don't have access to them, but I've kind of brought that up. So starting, I think tomorrow, I'm going to have a little lecture on myself. But I'm sitting down with some other staff members, and we're going to all have access to the test questions, how they're written, how they're asked. I'll be able to start seeing your grades. So I'll start being more like a teacher now. So I'll have access to all that. So then maybe I can look forward ahead and kind of see how your questions are worded, written, and kind of give. No, I will not give test questions throughout the class, but I can kind of understand how they're writing them and specifically try to address it. And then I can see like where we need to address a little bit more, maybe some things that aren't in your slides. And you guys have to remember that just because we're going off of this book, this Jones Bartlett book, that you're technically tested on the DOT side of this. So it's not just Department of Transportation on how you drive and all that. No. So DOT regulates EMS. And there's 50 different states that we go over, and you're tested on the national standard. The book is chosen and it's written off the national standard. So understand that you may see probably 60% out of your book of what is written throughout the national curriculum, but you're tested in National Registry on 100% of what is out there. So that's where the confusion may be, that some of these test questions may be written because they didn't go over them. That's just something we're going to have to deal with. That's the way I had it in all of my classes. Registry's the same way. I had trouble with my paramedic registry. It took me a couple of times to pass. And it was all by like 1 point, or I got it on my 3rd attempt. I'd already got upset and frustrated and all that, and finally I just was like, kind of let everything go. So I will get into that. I will be able to see your tests. I will be able to see them prior. I'll see a test bank. I will not be able to see the questions that's populated in your quiz. I know I'm rambling. Do you guys have any questions about this chapter? I know that some of you folks have spoken up and said that you've had to deal with some of these things, and you constantly deal with them. So your input is helping us out drastically in learning and just your experience on
what's happening, how to treat it, what you're going to see. I'm not a big person on war stories, but I think it kind of teaches you guys a little bit of what's out there, what you're going to see. I'm giving personal experiences that I feel that are prevalent to the class, and that's the reason why I spoke on them. I don't talk about, oh, on this call, I ran this type of call and did this. I could go there all day long, but I'm just going to say that it's very important that, in my eyes, that we teach each other, that we kind of help each other out. So if you don't have any questions, I'm going to hit the next slide so you can see the code. I did take time to type that down. Your code tonight is 87476. I'm going to type that down here too. 87476. I hope that everybody has gained something out of this. Please let me know if you have any questions. I will take a few minutes to sit down and type in the questions for the Facebook that I hope to see your responses so we can move forth from this. And I will try also to sit down over the weekend and type in for Tuesdays so y'all can have some pre-questions and do a little bit of learning on your own. All right, folks, I'm going to close out for the night, and I will take care of some things on my end. Other than that, I will see y'all Tuesday night. Have a great weekend. Stay safe.